Hello, everybody. My name is Krista Cooper, and I'm the physician assistant in the Rush HD Clinic. And I'm going to talk to you today a little bit about palliative care for Huntington's disease. So first, let's answer the question, what is palliative care? Palliative care is a specialized medical care for people with any type of serious illness, and it really is focused on providing relief of the symptoms from the illness and also relief from the stress of the illness. Palliative care also focuses on improvements in quality of life through a more holistic approach, and really focuses on not only the person living with the serious illness, for our purposes, Huntington's disease, but also on their caregivers and their family members that are impacted. A myth that I've heard before that I want to dispel is that palliative care is not just for cancer patients. So I think historically people have identified or associated palliative care with patients that are suffering from cancer, but the importance of palliative care in advanced neurodegenerative conditions such as Huntington's disease is becoming more widely recognized. Another term that we sometimes use instead of the term palliative care is supportive care, which is really what palliative care is all about. It's about support. So palliative care, it's an approach to medicine and an approach to patients and families that helps them cope with illness through symptom management. So how can we manage symptoms in the best way? Psychosocial support. So we have a wonderful social worker in our clinic that helps a lot with the psychosocial support of living with Huntington's disease. And also planning for the future. So you've probably heard us ask about advanced directives and advanced care planning, and that's really all a palliative approach to Huntington's disease. Palliative care can be provided by specific healthcare providers that are palliative care specialists, but many aspects of palliative care are provided by neurologists or other healthcare professionals. So you may not realize it, but in Huntington's disease clinic, we are often providing palliative care. And I really liked this quote. So the focus of palliative care is people rather than the disease, which is really important that we don't lose sight of people that we're caring for. So there's evidence that palliative care can actually improve outcomes for patients with neurodegenerative diseases like Huntington's disease. So at the top there, quality of life, palliative care can help improve. Advanced care planning, like I mentioned, emotional well-being, and then something we don't talk a lot about is spiritual well-being. It can help improve or lessen burden and grief, and then it really can have a positive impact on caregiver support. So some myths. Palliative care is not the same as hospice. I think there's a lot of confusion between those two terms. It is not euthanasia or assisted suicide. It is absolutely not giving up on patients. So if we ever recommend palliative care to you, we are definitely not giving up. It's not doing nothing. It's focusing on the quality of life. And like I said, focusing on the person rather than the disease. It is, palliative care is not for only the imminently dying individuals. And I already mentioned that it's not just for cancer. So these are all myths that I hope I've dispelled here. So then what is hospice? Hospice is medical care and support for caregivers when curative measures have been exhausted, and this is the important part, and life prognosis is less than 6 months. So that 6-month timeline is not necessary to receive palliative care. So Medicare has mandated some services that are always provided when someone's on hospice care. So first, you have a whole interdisciplinary team of hospice professionals. You can more easily get home medical equipment, obviously medication, respite care for caregivers. Hospice teams do have someone on call 24 hours a day, so if something happens in the middle of the night, patients that are receiving hospice can be cared for immediately. It can be provided inpatient. It can also be provided at home. And then hospice also helps with bereavement after an individual has passed away. So let's compare the two, palliative care versus hospice. So palliative care can be provided at any age. It can be provided at all stages of Huntington's disease. So even in the early mild stages, we can provide some palliative care. You can receive palliative care with other treatments. So you can receive all your normal medications for Huntington's disease and still be getting kind of a palliative care approach. Palliative care is not end-of-life care, and it can be delivered by a neurologist, a palliative care specialist, or other healthcare providers. So now hospice, you can see, is a little subset of palliative care. Again, hospice can be provided at any age, but it is not provided at all stages. It's only provided at end stages when life expectancy is less than 6 months. And hospice is typically provided by hospice specialists. So we really do need to refer to a hospice team in order to provide that type of specialized care. So about Huntington's disease, what really matters to people living with Huntington's disease? And this might be different for each individual, but this is kind of some general themes that we've seen in the literature when this question is asked. What matters to you? Spending time with family is a big one that really matters to people with Huntington's disease. Having control and choices. It can kind of feel a little bit like HD is out of your control, the symptoms, and being able to have some type of control and choice is really important. Receiving essential and accurate information, emotional support, and then management of not only the physical symptoms of Huntington's disease, but also the mood and cognitive and psychological symptoms. Communication and family support. And you can see here, I included the motto from the Huntington's Disease Society of America, family is everything. And then last and certainly not least is enjoying your life. That's very important to find enjoyment. So palliative care for Huntington's disease. So although we do certainly have options for symptomatic treatment in Huntington's disease, we don't have a cure, we don't have a way to stop the progression. So a palliative approach to how we care for you is really important throughout all stages of the disease. HD can be a little tricky because it's not always predictable in how it's going to progress. So that can sometimes make prognosis very difficult. And as I'm sure many of you know, HD progresses over many years or even decades and can really have a long palliative care phase. And symptoms of advanced HD, so people that are maybe in the later stages of the disease, their symptoms can really fluctuate from day to day. So palliative care issues in Huntington's disease. Maybe the most obvious for some individuals is the chorea or other issues with movement. But if you ask a lot of families or even patients, they may tell you that the issue that's more important to them are behavioral or mood changes. Some HD patients can experience pain, and that would be an issue that we can address in a palliative care manner. Weight loss is another thing that we always want to monitor. Demoralization or spiritual challenges, that's an interesting one that we don't often have time to discuss during a visit in our clinic. High caregiver demands or burden, and then the high variability and complexity in prognostic prediction. So it can be really hard to predict what's going to happen in the future. And then the complex bereavement after a loved one has passed away. So some challenges of providing palliative care in Huntington's disease are just kind of nationwide. People with serious illness that's not cancer, they tend to have this unmet need in terms of psychological support and symptom control. Definitely breaking the myth that palliative care is only useful at the end of life. That's why sometimes we use the term supportive care, because I have heard a lot when I mention palliative care to families or patients, they get very concerned that I mean hospice. So really being able to understand the difference between the two and really understanding that palliative care is, like I said, at any age and at all stages of Huntington's disease. Sometimes there's a failure to address end-of-life issues before the cognitive changes of Huntington's disease occurs. So we talk about advanced care planning and signing advanced directives and making sure to identify a power of attorney. And we encourage everybody to do that in the very early stages of Huntington's disease, maybe when symptoms are just very mild, or maybe there even are no symptoms, because as the cognitive changes occur, it can be more and more difficult to address these end-of-life issues. And then in particular, younger individuals can have a hard time addressing, something that seems very far away, and it can be very sensitive to discuss having a power of attorney or a surrogate decision maker. And so sometimes people will just kind of avoid these conversations altogether, which makes providing support and palliative care more challenging. So palliative care at Rush. So obviously your Rush HD team provides all of these services, but it also can be provided in the home if we have an order for home health palliative care, and if we can get that approved through your insurance. So HD specific care is very important, but Rush Hospital also has a dedicated palliative medicine department and palliative care team. So there may come a time, not necessarily for everybody, but there may come a time where the Rush HD team recommends a consult with the specialized palliative care team for certain situations. And then another quote, palliative care is about living as well as possible for as long as possible. So it's not giving up, it's not doing nothing, it is trying to get the most out of your life and live as long as possible. So indications for specialist palliative care may be if the patient or family are experiencing really significant distress that's just not improving, or if there's significant concerns or worries about the future with a really more in-depth focus on future care planning or advanced care planning. And then if there are spiritual concerns, we can recommend a consult with one of our Rush chaplains that's non-denominational and can address a variety of spiritual beliefs. So palliative care in the home. So some home health companies do provide palliative care services. So some companies provide not only hospice care in the home, but they also have palliative medicine home health providers as well. One of the goals of getting palliative care in the home is to prevent emergency room visits and hospital stays, so to keep people in the home for as long as possible. And palliative care specialists that come to your house, they can coordinate with your Rush HD team and also your primary care provider. And I think I just want to strive this point that you do continue existing treatments. So if you are receiving palliative care in the home, that doesn't mean you have to stop all of the medicines that your Rush HD team has recommended. You continue all of that. This is just in addition to those treatments. And then they really can do a good job on spending the time with you and your family to educate on advanced care planning. Another thing with palliative care is when do we identify, or how do we identify when someone is really in the last 6 months of their life and really hospice is more appropriate at that point? So reduced level of consciousness is one. If people are sleeping just more and more during the day, that is often a signal that hospice may be helpful at that point. People may become hyperactive or agitated, or they may become hypoactive. So that either means they're like agitated and really active, or they're kind of less so and more subdued. So any type of kind of acute change in mental awareness with like the fluctuations, that can be an indication that it might be time to transition to hospice. If there's a significant weight loss or decreased appetite, that can be a signal. And then if the patient is bedbound or they're really having very little interaction with their environment, that may also be an indication that we should get the hospice team involved in care. So I just want to thank you for listening to my presentation. Obviously, your entire Rush HD team is here for not only our patients, but also their family members. We just want to be supportive in any way we can. If you have more questions or are interested in maybe receiving a palliative care consult or in the home, feel free to talk to Dr. Hall, Dr. Patel, or myself, or anybody on the team at your next appointment. All right, thank you.